Hello students, and welcome to part 2, chapter 21, kidney disease. Now we are going to talk about nephron diseases. We have first acute glomerulonephritis, right? So right there you understand that this is going to involve the nephrons and the glomerulus, right? Or which is also denominated or also known as nephritic syndrome. Okay, so the disease process, this is an inflammation that affects the glomerula, as I mentioned, which are the small blood vessels in the cup membrane of the head of the nephron, and this is the third leading cause of a stage 5 CKD, also known as end-stage renal disease, okay, nephritic syndrome. Clinical symptoms, we are going to see hematuria. We know what is that. It's blood in the urine, and proteinuria. In the urine analysis, we are going to see protein, right? Although edema and hypertension, just think about it, is the end-stage renal disease. So the patient is going to collect a lot of fluid out of the circulatory system. That's why edema is going to be present. And hypertension also may occur. These individuals may experience anorexia in advanced stages, which contributes to feeding problems and malnutrition. They don't want to eat, right? So the body is basically looking for protein inside the storage. And that is why also the protein is being eliminated in the urine. If the disease progresses to more kidney involvement, signs of oliguria and anuria may develop. So oliguria is low urine output, and anuria is lack of urine, okay? Now we have medical nutrition therapy for this condition, glomerulonephritis or nephritic syndrome, okay? Try to memorize that because the doctors, when they give report, they can use either or, okay? And it's very important to be updated on these names, because at 7 a.m. when you go to the hospital and the doctor is doing rounds and all the nurses and residents are following the doctors with the reports, right? You need to be familiarized and understand what the doctor is talking about. Diet modifications are not crucial in most patients with acute short-term disease, right? Diet modifications are not crucial in most clients with acute short-term disease. Output and insensible losses determine fluid intake recommendations, okay, in this particular stage of the kidney disease. So now we have nephrotic syndrome. The disease process is that a nephrotic syndrome or nephrosis results from nephron tissue damage to the major filtering membrane of the glomerulus, thereby allowing protein to pass into the tubule, okay? So this high protein concentration may cause further damage to the tubule. Yes, because it's not their natural habitat, okay? Protein shouldn't be going through these tubules. Disruption of both filtration and reabsorption, which is the functions that we studied before, of the nephron ensures. Common causes of nephrosis include infection, medications, neoplasm, preeclampsia, progressive glomerulonephritis, or diseases such as poorly controlled diabetes and systemic lupus erythematosus. I want you to remember these conditions, because when you come to the 4th and 5th semester, we are going to speak about these, especially in the 5th semester, you're going to talk about, you're going to learn about the diabetes, but with me, you're going to study systemic lupus erythematosus, right? And also we're going to see some of these nephrotic conditions, okay? That's good to know. Okay, that's good to know. Very good. Now, table 21.2, we are going to speak about glomerular syndromes. And we have the syndrome, acute nephritic syndrome, which we described a few minutes before. Then we have the rapidly progressive glomerulonephritis, okay, nephrotic syndrome, which we are analyzing now, chronic kidney failure, and asymptomatic hematuria or proteinuria. Okay, and then you have the clinical manifestations that you are more than welcome to review. Now we are going to the clinical symptoms. Remember, we are just covering right now the nephrotic syndrome, okay? So the clinical manifestations, the large urinary loss of protein from nephrosis is going to be more than 3 grams per day or more in adults, leads to hypoalbuminemia. Of course, if you are losing protein, you are losing albumin. That's why you're going to have hypoalbuminemia. Okay, we are going to have edema. Remember, the albumin, the protein, is the magneto that holds the fluid into the circulatory system. So when you have hypoalbumin, low amount of protein, then the fluids are going to start going to the other part of the body, not in the circulatory, but are outside of the circulatory system. So you have edema and ascites. We know ascites is related to the liver, right? And the accumulation of fluids is going to be on the abdomen. So inadequate protein in the blood leaves fluid to accommodate in the abdominal cavity, ascites, yes. As osmotic pressure is too low to pull fluid back into circulation, okay? Now, the body will catabolize tissue proteins in an attempt to compensate for urinary protein losses, okay? So, catabolism is very important to remember. General malnutrition follows. Remember the catabolism that occurs with the proteins, okay? General malnutrition follows. Severe edema and ascites often mask the extent of body tissue wasting. Now, medical nutrition therapy for nephrotic syndrome. The goals are to control major symptoms, replace nutrients lost in the urine, and reduce the progression of CKD, and to decrease the risk of atherosclerosis, right? So now we're having the protein, a diet containing moderate amount of protein, 0.8 to 1 kilograms per kilogram of body weight per day. And this is important. You are not in charge of making this calculation. Usually it's the dietitian, but please understand it's going to be grams per kilogram of the body weight per day, with an emphasis on protein from high biologic value sources, including soy protein, blood urea nitrogen, and glomerular filtration rate level. Help the dietitian to tune up the ideal total protein intake. So the dietitian is going to order or is going to request the blood results, right? To double check the BUN, the blood urea nitrogen, and also the GFR levels. When patients experience an elevated BUN level and decreased urine output, they may need to restrict the dietary protein intake. Okay, so elevated BUN means the patient is in that dehydration state. Energy. Total energy intake should be adequate to support nutrition status. Please, guys, don't get anxious that you are not having the full understanding of the blood results, the BUN. Okay, little by little you are gonna learn. But remember, we are building knowledge on top of knowledge. So it's crucial that you put all your efforts to understand how this works, because as you get into more advanced courses, you are going to be required to recall this knowledge. When you get into the third, fourth, fifth semester, that is not the time to figure out what is the meaning of blood urea nitrogen, for example. What are the normal levels? No, at that point you should be able to recall the meaning and the normal level. So memorize your laboratory now. Okay? Okay. Energy. Total energy intake should be adequate to support nutrition status. Needs may be as high as 35 kilocalories per kilogram per day. Liberal complex carbohydrates provide sufficient energy in kilocalories and help to combat the catabolism of tissue protein and to prevent starvation ketosis, right? And we already reviewed the ketosis definition when we were checking and we were studying diabetes, right? So here are a few refresh some terminology: hematuria, proteinuria, oliguria, anuria, nephrosis, lipiduria, blood urine and nitrogen, and ketosis, the accumulation of ketones, which are intermediate products of fat metabolism in the blood. Okay, and usually this is happening more in diabetes type 1, right? But it could happen also in type 2. Fat. Total fat intake should not exceed 30% of total kilocalorie per day, and cholesterol intake should not exceed 200 milligrams per day. So dietary intake of fat and cholesterol may help to alleviate this lipidemia and the resulting risk for atherosclerosis. Let's talk about sodium and potassium. To reduce symptoms of edema, patients should limit sodium intake to 1 to 2 grams per day. Sodium overload is difficult to treat because of the characteristic hypoalbuminuria and hypotension, and oliguria impairs the renal clearance of potassium. Now, let's talk about calcium and phosphorus. Some calcium is bound to the albumin in the blood. As albumin is lost through the damaged tubule, bone calcium is also lost. Okay. In addition, low serum levels or active vitamin D decrease calcium absorption. Individuals consume 1 to 1.5 grams of calcium per day, but not to exceed 2 grams of calcium, including supplements and or calcium-based phosphorus binders. Patients should limit phosphorus intake to 12 milligrams per kilogram per day. And again, these are numbers that the nutritionist is going to understand better, but you, as they are going to create a meal plan, but you at least can create a meal plan with overall recommendations, right? You can say, for example, just an example, right? The patient is going to get in the morning scrambled eggs with banana, la la la. You are not saying 1 gram, 2 grams. Those are for the dietitian, but you need to understand the product that the patient is going to eat. Fluids. The healthcare team may restrict fluid intake in response to urine output and insensible losses. If not, then the patient may consume fluids as desired. Very good. Now we are switching gears to kidney failure. So two types of kidney failure, acute or chronic, have a number of symptoms that reflect interference with normal nephron functions and nutrient metabolism. Now we have acute kidney failure, and we are going to review right now the disease process. So healthy kidneys may suddenly shut down after metabolic insult or traumatic injury, okay, thereby causing a life-threatening situation. Primary risk factors for the development of acute kidney injury, also known as acute renal failure, okay, include older age, diabetes, and hypertension. And that's good to know. Primary risk factors for the development of acute kidney injury include older age, diabetes, and hypertension. These are three categories. There are three categories of acute kidney injury. We have the pre-renal, that is before the kidneys, okay? Pre-renal injury is the most common form of acute kidney injury, the pre-renal, accounting for almost 70% of cases, involves inadequate blood flow to the kidneys and a subsequent reduction of GFR, glomerular filtration rate. Common causes include renal vasoconstriction or occlusion. So there is a vasoconstriction, there is occlusion, nephrotoxic medications, okay? For example, your NSAIDs, your angiotensin converting enzyme inhibitors, yeah, right? Your ACE inhibitors, your prils, your angiotensin receptor blockers, systemic vasodilation medications, systemic vasodilation that happens when the patient is having sepsis or shock, okay? Um, and severe dehydration and hypotension. Severe dehydration and hypotension. Now we have the second category is the intrinsic, means the issue happens inside of the kidneys. Common causes include glomerulonephritis, acute tubular necrosis, acute interstitial nephritis, vascular obstruction, infection, or nephrotoxicity from antibiotics, antimicrobial agents, radiographic contrast agents, as I mentioned before, your dyes when you do the CT scan or MRI, chemotherapy agents, or other nephrotoxic drugs. And then the third category is post-renal. So you have pre-renal before the kidneys, you have inside of the kidneys, and then you have after the kidneys. And the common cause includes prostatic hypertrophy. So that's why I always recommend to know the map. The prostate is outside of the kidneys with urinary retention, urethral stones, and other obstructions like tumors, blood clots, etc. So acute kidney injury occurred in as many as 1 in 6 hospitalizations, 1 of 6 hospitalizations, and significantly increases the length of a stay in the hospital and also increases the cost and mortality. So this is going to be in your NCLEX alert, acute kidney injury. Some individuals do not regain normal kidney function, yeah, and the disease then progresses to chronic kidney disease, from acute to chronic. So then individuals with AKI, acute kidney function, who have a high risk for developing chronic kidney disease are those with reduced GFR, repetitive or long episodes, so acute kidney injury, endothelial damage, we are talking about the circulatory system right now, the endothelial, right, and persistent fibrosis. Clinical symptoms, we have here the acronym RIFLE, is the RIFLE classification, which assesses the severity of risk, injury, failure, and the outcomes of either loss or ESRD, which is your end-stage renal disease, and the acute kidney injury network criteria. Classify the degree of acute kidney injury. So now the diagnostic criteria for AKI are an increase in serum creatinine levels and oliguria. Okay, creatinine is the most reliable factor to test your kidney function. Creatinine and oliguria, we know oliguria is a reduced amount of urine, which occurs when cellular debris from the tissue damage blocks the tubules. Okay, so that is the diagnostic criteria. Increase in creatinine and oliguria, okay? And this is happening when the cellular debris from the tissue damage blocks the tubules. Now we have proteinuria or hematuria may accompany diminished urine output, right? We have oliguria, so now instead of that, probably proteinuria or hematuria. And other symptoms are going to be nausea, vomiting, fatigue, muscle weakness, muscle swelling in lower extremities, itchy skin, confusion, uremia, which is the amount of urea in the urine, and malnutrition. Fluid balance also becomes a crucial factor, right? Continuous renal replacement therapy, which is a type of dialysis, support kidney functions for some critically ill patients. So now, we understood the RIFLE, right? Criteria, which is the risk, the injury, the failure, right? The loss or the end-stage renal failure. Now, medical nutrition, basic objectives is to maintain nutrition status while the patient experiences marked catabolism. Number one, treating the underlying cause, why the patient is having, right, this type of reaction, right? This malnutrition and catabolism, right? What is the cause? Treating the underlying cause. Two, preventing further kidney damage and complications, right? Three, correcting any fluid electrolytes. So remember, with kidneys, we have to correct the nutritional part, the fluid part, okay? And or uremic abnormalities. And also, loss of appetite is common, often require enteral nutrition support, parenteral nutrition support may be necessary as well. And we know those types of nutrition from previous chapters. Now, the principles: nutrition support in acute E patient help reduce the risk for energy and protein nutrition. Again, nutrition support in acutely ill patients help reduce the risk for energy and protein malnutrition. Okay, so now we need to follow the following. Protein for supporting kidney function and for preserving lean tissue is important. Recommends a protein intake of 0.8 to 1.2 kilograms per kilogram for patients who are not receiving dialysis and who are not experiencing catabolism. That's extremely important. So the amount of protein depends on the status of the patient, if the patient is on dialysis or not. Individuals who are experiencing catabolism or who are on dialysis may need 1.2 to 1.5 grams per kilogram of daily protein. So you see, if the patient is having catabolism or is on dialysis, the amount of protein is going to be higher. Energy. Energy intake in the range of 25 to 35 calories per kilogram. The dietitian will adjust this amount on an individual basis depending on metabolic stress and the nutrition status of the individual. If the patient is on peritoneal dialysis, the total energy intake should include energy obtained from the dialysate, which is the part of the components when the patient is receiving dialysis, right? Now, sodium and potassium, okay. During a diuretic phase, patients may lose excessive electrolytes, your sodium, your potassium, because the patient is taking too many diuretics. The diet should replace losses of both sodium and potassium 2 to 3 grams per day during this phase. Blood pressure trends and the presence of edema will determine any necessary adjustments to this level. So edema is a crucial factor here in determining what the nutritionist is going to order. During oliguria or anuria phases, the healthcare team may place the patient on electrolyte restrictions because of their accumulation in the blood and increased risk of hyperkalemia, a potentially fatal condition. So if the patient is having low urination or no urination, why are we going to provide, right, more fluids and electrolytes? We cannot. We have to put it on hold because we don't want to cause hyperkalemia, which is a potentially fatal condition. Phosphorus and calcium. Dietary phosphorus intake based on body weight with a range of 8 to 15 milligrams of phosphorus per kilogram or body weight. Hyperphosphatemia during anuria phases results in calcium reabsorption from bones, so phosphorus binders help prevent phosphorus absorption when taken with meals. Then we are going to also consider vitamins and minerals and fluids, right, depending on the hydration status. And insensible fluid loss may increase because of fever, and sensible fluid loss is urine output, vomitus, and diarrhea will vary considerably among patients. A starting point recommendation of 500 ml of fluid plus urine output daily has to be reviewed and considered. So now we are going to enter into the chronic kidney disease, right? And when we come back, probably we're going to stop here, okay? And then when we come back, we are going to check chronic kidney disease.